Perfect. Well, good morning, everybody here in person and those online. It's really a pleasure to introduce Dr. Benjamin Hibbert from Mayo Clinic, Rochester. I actually had the pleasure of meeting him in Rochester when you gave over there. I think it was a cath conference a few months, like last year, so or year before that. So it's wonderful to have you here. Ben, he did his training at the University of Ottawa. He's done wonderful work that he did at the Ottawa Heart Institute, a lot of work in interventional work, structural, but a lot of work in cardiogenic shock. And something that we've invited him to speak here today is the DOREMI trial that they published in the New England Journal of Medicine. A really interesting research that he'll talk to us about, not only from the cardiogenic shock perspective, but something that I was very intrigued, and that was one of the reasons that I said, like, we have to get Ben over here and learn from him and connect with our research team, is the pragmatic trial design that I'm very interested in, how he'll tell us how he conducted the trial at very low cost. He's published over 200 papers, has been tremendous at building research teams, and I guess now Mayo has recruited him to build this now over there at Rochester, so I think we're honored and thrilled to have you here.
Perfect. Well, first and foremost, thank you very much, Dr. Sandoval, for the invitation. I'd also like to extend a thanks to the foundation for the opportunity to come here and speak in Minneapolis. I know the quality of the faculty that works here in Minneapolis and the quality of the work that's done, so it's a real privilege to be able to speak to you guys today about inotropes, cardiogenic shock, and the DOREMI trial. So as Dr. Sandoval mentioned, I'm an interventional cardiologist. The other hat I wear is critical care cardiology. So I didn't do formal training in critical care cardiology, but I always tell all the fellows, I've actually never attended on a ward. I've only ever done ICU. So I'm one of the older guys that snuck in before the training requirements changed to also be co-trained in critical care. So again, I'm going to talk to you guys today about critical care, but I think one of the things that's really important to highlight is the evidence base and the knowledge gap that exists in the practices that we do. Both cardiology and critical care cardiology produce large amounts of data. So there's thousands of papers that are published every year. However, a lot of these papers are of lower quality, so they're observational data sets. And then we turn around and we use those observational data sets to inform our understanding of disease and clinical practice. And so a lot of the practice that we actually do is founded on poorly justified beliefs, and we use these beliefs to treat patients. And this has led us astray before, and there's lots of examples of this in cardiology, but these are just some of probably the more egregious things that we used to do, not because we didn't know any better, but because we used poor quality evidence to justify adoption of practice. So one of the things I teach all the fellows, intensive glucose control. When I was an internal medicine resident and when I was doing my cardiology training, I used to run around at night and make sure everyone had super tight glucose control because we had a single randomized trial that suggested there was potential benefit. And it took 4 randomized trials before we stopped that practice because we believed so much in it. And we were actually treating these patients, and there was a number needed to harm of 33 for death. So most of the intensive care units I rounded on had more than 30 beds. So we were killing 1 to 2 patients a month by adopting this practice. The CAST trial, I'm sure all of you are familiar with. PVCs were associated with bad outcomes post-MI. So of course, if we suppress the PVCs, that must be a good practice. And of course, now we know that was associated with a number needed to harm of 21. And if we stick to critical care cardiology, targeted temperature management. So again, most of my fellowship and even my early staff years when I started, we continued to do therapeutic hypothermia. I would come in at night, we'd activate the cath lab, we'd put cooling catheters in, we'd cool everyone down. I actually participated and ran one of the trials, Capital Chill, which we did when I was a resident, looking at moderate versus mild hypothermia. None of this works. We know that now. We have multiple clinical trials which suggest that we were keeping our hands busy while our patients were doing what they were going to do. Epinephrine for out-of-hospital cardiac arrest, something that seems so foundational, is associated with a number needed to harm of 166 for survival with severe neurological impairment. So all of these things that were dogma in critical care cardiology and cardiology were reversed when we finally did proper studies to implement them in our practice. And so this evidence base and the knowledge gap that we have often lags behind the clinical trials that we get. And that's because the way we develop evidence, we have to give opinions and guidelines will often tell you what to do, but they don't tell you, or it's not clear that the evidence supporting those suggestions is very poor. And so we need guidelines better to reflect uncertainty. So rather than giving a recommendation if there isn't good data, they should probably just say we don't know, rather than giving an opinion. They should provide a roadmap to future research, and they should help clinicians understand the limitations. We need randomized clinical trials. Randomized clinical trials, as you guys all know, are incredibly difficult to run. They can be prohibitively expensive, and we need to rethink how we do clinical trials so that we can test more hypotheses, get a better evidence base so we know what we're doing with our patients. And we need iterative processes. Just because a randomized clinical trial 30 years ago in the context, in a certain clinical context, showed benefit, it might not with contemporary care, contemporary medicines. And so it's okay to test, therapies that we feel are beneficial if the clinical milieu has changed. So I'm here today to talk to you guys about cardiogenic shock because that's one of my research interests. All of you guys know this. This is primary cardiac dysfunction leading to critical organ dysfunction. It is a common presentation for both ischemic and non-ischemic heart disease. And more commonly, it's becoming a presentation of non-ischemic heart disease. So if you go back 30 years ago, it was predominantly a presentation with myocardial infarction. And more, as we're getting better and better at revascularizing patients are living longer, we're having more patients coming in with shock as a presentation of their long-standing non-ischemic heart disease or heart failure. And it still has a very high mortality and morbidity. So this is one of the diseases in cardiovascular medicine that still has an astronomically high mortality. And the reason that is we don't have a lot of prognosis-altering therapies. So this is from Alain Combs' review article in The Lancet in 2020. If we actually look at the therapies that we give patients with cardiogenic shock, probably revascularization modulates survival in patients that are coming in with an MI. But a lot of the other things we do, we don't have data to support that these things work. Vasopressors, although we haven't tested them against placebo, we have some evidence that norepinephrine might be beneficial. I'm going to review the data on inotropes. We've tried things like nitric oxide synthase inhibitors. Those didn't work. In the last 5 to 10 years, MCS has become really hot. But again, like most of the therapies in cardiogenic shock, as we've gotten better data, we've learned that these therapies are probably not modulating morbidity and mortality, at least to the extent that we feel or felt that they did when they first came to market. And so this is some work that's been done by one of my PhD students, Richard Jung, and this is still under review. But if we look over the last 25 years, 2.3 million patients, over 148 studies, there's a decent drop in mortality in the early 2000s when there was widespread adoption of revascularization, and then mortality has been completely stable. So we have not dented mortality in cardiogenic shock in almost 30 years. And why is that? I think that's because we don't have good data. This is not an issue with we probably can't modify the disease process. We just don't know how to do it because we continue to practice without evidence from randomized clinical trials. And when we look, this is a review paper by Dr. Thiele, who's one of the leaders in cardiogenic shock. You can see almost all, I can see, you probably can't see, that font's pretty small. You can see almost all of the recommendations are B or less, and so they're not supported by any clinical trial data. They're us licking our fingers, putting it in the air, and telling you what we think is the best thing to be doing based on expert opinion. And again, cardiogenic shock has been notoriously difficult to do clinical research in. So you can see this is again from that same paper in 2020. We had 4 trials with more than 100 patients. So we just had no evidence. And this is getting better. Cardiogenic shock has become, a bit of a hot topic, and there's lots of trials being done now. But a lot of trials were initiated. People refused to enroll their patients because these patients were so sick and we knew what to do. And so we just had no evidence. And you can see we had IABP shock 2 and culprit shock, which were a little over 600 patients. We had Triumph, which was stopped early, looking at telarginine. And then we had the shock trial, which only had 300 patients. And now we have DOREMI, which I'm going to present to you today. ECLS shock just came out in the fall, 420 patients showing routine use of ECMO and AMI shock doesn't do anything and probably is associated with harm. Danger shock will be presented at ACC, and that's going to be, I think, another landmark trial, so looking at use of Impella and AMI shock. We have RECOVER 4, which is also an Impella trial, and I'm going to tell you guys a little bit about DOREMI 2 that is coming. And so the reality is when patients come in and they get admitted to my ICU with cardiogenic shock, we are sailing the stormy seas and we don't know where to go. We don't know how to deal with this problem, and that's just the reality. And again, when I'm teaching fellows, I'm always like, is it an MI? Can we revascularize them? And then after that, it probably really doesn't matter what we do. These patients, we're going to offer them supportive care. We hope they get better. We hope they have organ recovery. But as far as we know right now, everything else we're doing is a hypothesis. So what are the objectives of the talk today? I think I've highlighted a little bit some of the evidence gap in cardiogenic shock management. I'm going to go over some of the evidence supporting the use of inotropes. I'm going to review the outcomes of the DOREMI trial. I'm going to talk a little bit, as Dr. Sandoval alluded to, about integration of resident training into running a clinical trial and what are some of the future directions. And I'm just going to highlight these super impressive young people. The work that I'm doing today was all done when I was in Ottawa, and these are some of the trainees. So Rebecca Matthew was a cardiology fellow in Ottawa. She's now the director of the CCU, and her and Pietro De Santo, who's just finishing his critical care training, did a PhD in clinical trials with me, are the two co-first authors of DOREMI. Simon is a crit care fellow currently who finished his cardiology and will be coming on staff in Ottawa. Richard is an internal medicine resident, Richard Jung, and I'm going to show some of the work that he's done. He did a PhD with me as well, and he's going to be hopefully an interventional cardiologist when he all grows up. Some of you might know Trevor Simard. He's an interventional cardiologist at Mayo with me. Shannon Fernando was a fellow in Ottawa, participated in a lot of these trials. He's now a staff attending in Toronto. And Jeff Marbach was an interventional cardiology fellow who did crit care with Naveen Kapoor at Tufts and is now at OHSU. And I hope that as I highlight the importance of all of these trainees in this work and the investment that is and how you can develop these highly qualified personnel. All of these people will hopefully become academic cardiologists with an interest in critical care cardiology. None of them came into cardiology like this, and I think all of them kind of got that appetite by participating in DOREMI. So to go back to inotropes for a little bit, and I'm going to skim over this data quickly, but we have a lot of data to talk about today. So what did we know about inotropes? Well, the reality is inotropes are routinely used in cardiogenic shock. Patients come in, they get vasopressors, they're hypoperfusing, and will often add dobutamine and milrinone. Those are the two approved inotropes in North America. I'm not going to show you any data on levosimendan. That's another inotrope that's available in Europe. But the data supporting the use of inotropes in advanced heart failure isn't solid. So if we look at the PROMISE trial, which is over 1,000 patients, ambulatory heart failure, this is advanced heart failure. When we randomized them to milrinone or placebo, we increased mortality by 28%. And it was worse in the patients who had the most advanced heart failure, so the closest to cardiogenic shock. Increased hospitalization, increased adverse events. And that's why we don't use inotropes routinely in patients as outpatients unless it's being used for palliation. The Optine heart failure looked at a little bit of a sicker population. These are patients that were being admitted to hospital, but with very advanced heart failure, so probably more SCI-B cardiogenic shock or pre-shock. 48-hour infusion of milrinone or placebo. Again, no difference in death or median days in hospital, but increased adverse events with hypotension and atrial arrhythmias. And outside of that, there actually isn't a ton of great data on the use of inotropes. So these agents were approved, they're widely used, and we don't have a lot of great data. So what do the guidelines say? Well, the guidelines are actually pretty prescriptive about when you should use them, even though we use them widely outside of these areas. So the European Society says it's reasonable to use it in patients who have low output, who are hypoperfused, when you're bridging them to something, to a definitive therapy. The ACC and the AHA also gave that a 2A if you're using this as a bridge to somewhere. And it says it's also reasonable to use it in a palliative setting. So in patients who aren't eligible for MCS or transplant, and if you're just using it to make them feel better, as they go through the process of dying. And they give it a class 3 recommendation for long-term or continuous or intermittent use in any other situation that's potentially harmful. And so how DOREMI started is I was an early staff person in Ottawa. Rebecca was a first-year cardiology resident. We were rounding in the unit. We had a patient in cardiogenic shock. We decided we were going to use inotropes because they were hypoperfused. And she's like, do you want to use milrinone or dobutamine? And I said, pick. And she's like, in our center, everyone used milrinone. Milrinone was the drug to use. I said, I don't think there's any good data telling us to pick between the two of them. And so became our interest in which inotrope is the best inotrope to use in cardiogenic shock. So as with all of these projects, we started with a systematic review and meta-analysis. We're like, what data is actually out there? And we published this in 2019. And what you can see there is there's a total of 36 patients randomized in the medical literature between milrinone and dobutamine in patients with cardiogenic shock. There's a few observational studies, but that was the totality of the literature. So again, this is an everyday question in a busy cardiac intensive care unit. And I think, as you can see here, There's just no high quality data. And so we set out to do the DOREMI trial, and I was really interested in running pragmatic trials, and so we set up a clinical trial that was run de facto by the residents. So we set up a committee. The residents were involved in design of the trial. They attended the DSMBs. They helped set up the event adjudication committee, wrote the definition documents. And so this was one of my other hats I wore in Ottawa, was director of resident research. And so I thought, what a great idea. We'll get all the residents together. We'll have them participate in running this trial. So they were all on the IRB. They did all of the randomizations. They filled all of the data sheets. We had a coordinator to kind of help them make sure that they were hitting all their regulatory landmarks. But this is done by the residents. And you can see when we look at the author list, everyone that's in red there was a cardiology fellow when we did this trial. So we wanted to kind of hit as high as we could on the evidence pyramid. So we set out to do a randomized clinical trial. We wanted it to be blinded. We had learned a lot from doing clinical trials in Ottawa. If you don't blind, you just get bias. And so even though it's difficult, we felt it was important. We stratified the patients by left ventricular, right ventricular dysfunction. Drug titration was done clinically, because that's what we did at the bedside. So you would see how patients were doing. They got reassessed every 2 to 4 hours. And then if the patient was doing well, you stayed on your current dose of either milrinone or dobutamine. If they weren't doing well, you up-titrated it. And we did a composite primary endpoint, all-cause in-hospital mortality, resuscitated cardiac arrest, need for transplant or MCS, MI, stroke, or renal failure requiring RRT. Secondary outcomes, so all the individual components. We looked at a number of efficacy endpoints, total time on inotropes, need for mechanical ventilation, lactate, arrhythmias, and then a number of safety outcomes as well. And what I think is funny looking at this in retrospect is when we started this trial, I can't tell you, we had to go to ethics several times. We had several cardiologists who felt it was unethical to randomize between milrinone and dobutamine for something that doesn't have a lot of data. And so it took us almost 3 years to recruit all of the patients. We recruited in total 192 patients. We didn't get 127 patients. Now, 47 of those were transferred on inotropes already. It's a big referral center, so we get patients from other centers. They showed up on it. But 40 of the patients showed up, and the attending and the CC refused to randomize them because they believed they knew which inotrope was best, which I always chuckle when I present this, because again, no data, but people felt so confident they just refused to randomize their patient. 96 patients got randomized to milrinone, and 96 patients got randomized to dobutamine. And I think Table 1 reflects what we see in cardiogenic shock. Average age was 70. This is predominantly a white male population. So Ottawa, Canada, which is where we conducted this trial, is predominantly Caucasian. And so that just reflects the population. Most of our patients that come in cardiogenic shock, 60 to 70% of them are male. The EF at baseline was 25%, I think, again, reflecting the population that we recruited. Importantly, 92% of the patients were SCI C or SCI D. So these are sick patients that are coming in cardiogenic shock. When we looked at a comparison of milrinone and dobutamine for the primary composite outcome, it occurred in 49% of the milrinone group and 54% of the dobutamine group, not meeting the primary hypothesis, which was that milrinone was superior. Again, no difference in in-hospital mortality, 37% in the milrinone arm, 43% of the dobutamine arm. And interestingly, when we looked at any secondary outcome, there was no difference. So again, these patients are randomized, the drug's titrated in a blinded fashion. The New England, appropriately, I think, didn't let us put p-values on any of the secondary outcomes. But again, if you look at the point estimates and the confidence intervals, it didn't matter what we looked at. There was no more arrhythmia with dobutamine. We had no more hypotension with milrinone. When this was randomized in the patient population that we were using, the two drugs were really indistinguishable. We had pre-identified subgroups where we thought there might be divergent results. There was no difference based on sex, age, whether it was LV or RV dominant shock. It did not matter on the severity of the LV dysfunction or the presence or absence of renal dysfunction. Again, the drugs performed very similarly when randomized. And we had a whole hemodynamic and biomarker panel set that we did. We collected blood on all these patients on a regular basis. So again, the residents came in, collected the blood, spun it down in the centrifuge in my lab, put it in the freezer. So they were doing all of these steps. So we have all the blood. And again, when we look at VIS scores, when we look at urine output, creatinine, lactate clearance, it was bang on identical across. And so certainly there's some limitations of this study. So we only looked at in-hospital outcomes. Again, we're trying to do a pragmatic study here. Follow-up is difficult to do, it's expensive, you lose patients, but when they're in shock, you have them till they leave hospital. And so it is possible that differences existed between the treatment arms after they left hospital. We saw that in the shock trial. Shock trial is a negative trial. If you look at the primary outcome, it wasn't till later follow-up that there was divergence between revascularization and conservative therapy, although I don't think so. You know, every single endpoint was bang on the same between these two drug regimens, so I find it improbable that you're going to see significant differences in follow-up. Our study was designed to be pragmatic, and so you know, you didn't need a Swan-Ganz catheter to get into the trial to confirm that you had cardiogenic shock. If the clinician at the bedside you know, made the diagnosis of cardiogenic shock and didn't want to place a Swan-Ganz catheter, you didn't need to have one to get in. And so you know, unlike some of the other trials of shock where you need a PAC to get in, you didn't need it for this. That being said, we had an in-hospital mortality rate of 40%. So these patients were shocked, they did poorly, and that's the same mortality rate we see in other trials of cardiogenic shock. So I think we got the population right, despite not using a hemodynamic inclusion criteria. And so in conclusion, we were unable to demonstrate a difference between milrinone and dobutamine in the primary composite outcome or important secondary outcomes. And I think selection of inotrope can reasonably be based on the physician that's looking after, whether they're comfortable using milrinone or dobutamine, the cost and response to therapy. I think all of those things can be taken into consideration. And so, again, super proud of Rebecca and Pietro. So Rebecca presented this in the Resuscitation Symposium, got best presentation. And as Dr. Sandoval mentioned, this was published in August of 2021 in the New England Journal of Medicine. But DOREMI also gave us an opportunity to look at some other aspects of shock that we're interested in and challenge a little bit of dogma. And so Pietro went on. We were particularly interested in the response to beta blockers in patients who have beta blockers between dobutamine and milrinone. So classic teaching, and this is actually in the ESC guidelines, the patient is on a beta blocker when they go into cardiogenic shock, you're not supposed to use dobutamine because in theory those beta receptors are blocked. And so you're giving them an agonist when an antagonist is there, and in theory they won't have any benefit. Well, the nice thing about our trial is these patients were randomized, so it's not like we picked the drug based on what they were on when they came in. You know, this was all done by the computer. And so it gives us an opportunity to look at, well, how do patients do when they're randomized in a shock state and they're on a beta blocker? And because of the benefits of randomization, we ended up with equal numbers of patients on beta blockers in the milrinone and the dobutamine arm. And what's interesting is when we look at clinical outcomes, this was actually a surprising finding. We thought the patients on beta blockers would do a little bit worse. In terms of the primary composite outcome, there was no difference. But there was significantly less cardiac arrest in the first 24 to 48 hours in patients who were on beta blockers and less death. The mechanism of death and shock, if you follow and you look at the natural history, if you die in the first 24 to 48 hours, what typically happens is you don't just like melt away and we can't maintain your pressure because we usually maintain your pressure. We won't let that happen. What typically happens is you're pretty sick. You start VTing or VFing. We start shocking you, CPRing you, and then we spiral and you die. And what was interesting, if you came in on a beta blocker, we didn't see those events. And so that was a little bit surprising. When we looked at hemodynamic parameters, milrinone, dobutamine, there was absolutely no difference. So if you're on a beta blocker and you come in cardiogenic shock, it doesn't matter whether you pick dobutamine or milrinone, you have the same heart rate response, blood pressure response, VIS scores. And so again, you can use whatever drug you want. But what was particularly interesting and insightful was that beta blocker therapy in the preceding 24 hours in cardiogenic shock was protective. And that's the first time that's been looked at in cardiogenic shock where an antiarrhythmic in that first 24 to 48 hours might be beneficial. Now, I'm not suggesting you go give a beta blocker to your cardiogenic shock patients. That's probably not the right thing to do, but it just is interesting from a hypothesis standpoint that maybe modulating their arrhythmic risk is a therapeutic target. And that's never been tested in this patient population. So what about biomarkers? One of the things that's tough is when patients come in cardiogenic shock, there's a lot of shock scores and we try to prognosticate. I like the SCAI classification. It's super easy. It helps us communicate. Again, when I'm teaching the fellows, this is like communicating with a Killip classification about STEMIs. It helps me understand where the clinician looking after them feels this patient is. But sometimes we want to go beyond that and kind of look at, are there biomarkers that help us predict how patients are doing. And so risk stratification is helpful. It's helpful clinically. It's helpful in a research perspective. Lactate clearance has been studied a lot in septic shock, and there was a couple papers in cardiogenic shock in observational data sets, but there's nothing that's been validated in randomized clinical trial data. And it was unclear whether inotropes or differences in the inotropes had differences in lactate clearance. Now, 75% of the patients in this study had a baseline lactate before they were randomized. And so people were like, oh, how did you not have a lactate? Well, I'm like, some patients come in and they're shocked. And you randomize them before you get a lactate. And so the problem is all of your lactates thereafter are after therapy. So we excluded those patients because we didn't know, those patients had started therapy. In fact, we had 2 patients in this trial. I would say we had 2 patients that died before they got anything, right? They come in, they're in bad shock. We randomized them. The time from when we identified them to randomize them was less than an hour, but patients get VT-VF. They go to the cath lab, they die in the cath lab. And so sometimes clinical events can happen before you have an opportunity to get some of these blood tests. And we looked at both clinical and biochemical parameters that predicted survival. And when we looked at, because we had very highly detailed data sets on these patients, having a higher MAP was protective, being young was protective, not being mechanically ventilated was protective, and having lower use of vasoactive agents was protective, although interestingly, that went away when you adjusted for other risk factors. But when we looked at what were biochemical markers and we looked at a number of lab values, lactate clearance was the strongest predictor of how patients did. And it was actually a stronger predictor than any of the clinical parameters. So in the first 24 to 48 hours, if we look at how these patients did, and you can see the lactate clearance curves on the left there, you can see the proportion of patients that cleared their lactate. If you are able to resuscitate these patients and clear their lactate quickly, get rid of hypoperfusion, these patients generally do pretty well. It's a bit of a duh statement. And so this always happens in cardiogenic. If you're responsive to therapy, you do better. But it's not infrequent that there's discordance between lactate clearance and how someone's doing clinically. And when we looked at that, lactate clearance was a better predictor than how they were doing clinically. So if their vasopressors are being down-titrated, but their lactate's not clearing, you're not necessarily in a better place. And complete lactate normalization by 8 hours increases your chance of survival 4-fold. And so this is, I think, is important for risk stratification of patients that are in your unit. It's something that I follow routinely when I'm looking after these patients. And it might be something we can also use in early studies of cardiogenic shock. So again, I by no means think we should use surrogate outcomes if we are looking at hard clinical outcomes, but certainly if we're developing early therapies, looking at lactate clearance as a surrogate while we're developing these early therapies might be reasonable. Now, I've talked to you guys a little bit about inotropy, but the other hat I wear is I do structural heart disease. So I spend my time in the cath lab fixing valves and making holes and closing holes. And one of the things that we were particularly interested was, this Venn diagram where there's overlap between valvular heart disease and cardiogenic shock. So if you read the literature, it actually suggests that only a minority of patients with cardiogenic shock have valvular heart disease. Again, we had a very detailed population. And so Simon, who's currently doing his crit care training and is going to be a cardiac intensivist, was interested in looking at what is this relationship between valvular heart disease and outcomes in cardiogenic shock. And we published this in the Canadian Journal of Cardiology in 2022. And I find this very, very interesting, and this kind of spurred one of the other arms of interest in my research. So if you just look at the echoes of people coming in with cardiogenic shock, 40% of them will have a significant valvular lesion. So that's 3+ or greater MR, or severe stenotic lesions. So 5% of our patients have significant AS. That's not that common. But when you do have significant AS, it more than doubles your risk of dying. And so that's a bad valvular lesion to have in cardiogenic shock. And that also jives, I think, a little bit with my clinical experience. Those are the hardest patients to manage hemodynamically. And if you're not able to fix their aortic stenosis, it's a big problem. 1/5 of patients had significant mitral regurgitation. And again, I think I think that's going to go up. I think as we see more and more patients with heart failure-associated cardiogenic shock as opposed to acute MI, and what you're going to see is more and more of these patients are going to have functional MR, and a part of their hemodynamic management is going to be managing that functional MR. And then some of the patients, almost a fifth of patients had significant TR. And again, I apologize for the smaller font, but significant mitral regurgitation was associated with a 60% increase of risk of mortality. And so valvular heart disease, I don't think is that rare in a cardiogenic shock population, at least not in a contemporary population that we're looking at. So this is not the 1980s, 1990s AMI shock where 7% of patients are going to have a ruptured PAP or ischemic MR. I think as we shift to a more heart failure-oriented population, we're going to see more of that Venn diagram overlapping where these patients have associated valvular heart disease. And the question is this a potential therapeutic target? Now, there's certainly some lessons to learn, I think, from running DOREMI. So first and foremost, I think running pragmatic trials in difficult populations can be run in a low-cost, high-yield fashion. So one of the favorite things, we got a $50,000 grant to run this trial. We spent about $30,000 of it running the trial. Again, the residents did almost all of the grunt work as part of their research training. They were all involved. I haven't shown all the sub-papers that we got. But basically, this was just part of their research training. They owned it. They got involved in it. And having resident champions in our clinical trials is something that we've now rolled out. So every site that we bring on board in DOREMI 2, when we get the sites to identify a resident or fellow who's involved in the trial, who helps with recruitment, data collection, we actually have spent more on publication fees than we spent on running the clinical trial. We made the endpoints in hospital, so there was no follow-up. All of the protocol followed clinical care. So none of the blood tests, ultrasounds, anything added additional costs. So it was really, running the database, doing the educational events, following up on data and cleaning. We had a quarter of a research associate who was largely there to make sure that we weren't running afoul of any regulatory aspects of it. Because again, the residents are learning. The trial wasn't perfect by any means. We all still ran into a resident who randomized a patient at 3 in the morning, lost a consent. We had those types of usual things that occur while people are learning to run these types of trials. But I think as you see, we were able to answer, I think, a pretty simple question with very little resources. I think what I learned is that fundamental questions in critical care cardiology should be addressed. I don't care, how strongly you believe that a therapy is beneficial. If you don't have an RCT that supports that, I think you got a great hypothesis. You might have a lot of data supporting that hypothesis, but you don't know until you randomize, no matter how strongly you believe in it, no matter how many times you've done it clinically. And I think that's being adopted. I think it's getting better. It's still incredibly hard to randomize shocked patients because they're dying. And people feel uncomfortable with dying patients. And part of the education in running these trials and the educational events that we do is, the mortality has been the same for 20 years. If we want that mortality to decrease, we need RCTs. Because otherwise, we're just going to be doing the same things that we've always been doing that have been giving us a 35 to 40% mortality, and we're never going to learn. I think there are therapies out there. I think we can bend this curve. But what's going to do that is clinical trials. And I think, heart failure is probably the best example of this as a field, right? Heart failure had a horribly high mortality, and we've been able to bend that curve with clinical trial after clinical trial. And now we have, medical regimens that dramatically improve the outcomes of these patients, where if people refused to randomize and we just kept doing what we were doing, we'd probably still have a 30 to 40% mortality. And so I think things are getting better in cardiogenic shock. People are feeling more comfortable about randomizing these patients, and we're getting more and more data. And I think integrating residents into trial development, and I really believe this is part of building a team. This is a high yield endeavor. So we generated a lot of, I think, highly qualified personnel out of this. So, we took a group of trainees who were very interested in clinical cardiology, and I think we're going to end up with 6 or 7 trainees who all want to be cardiac intensivists and run clinical trials, which I think is great, and it's helped us build a network of these trainees. So this is, it absolutely takes obviously as an investigator, if you have a pile of money and you can just get essentially pros to run your trial for you, that's probably the most efficient in terms of your time. But this is a really efficient way to invest in your trainees, and it's helped me be more productive by generating these highly qualified personnel. I think it's going to help me be more successful in the future. So that time investment that I did teaching them how to run clinical trials, I think is going to pay dividends manyfold with time to come. So I'm going to just really quickly, I got 10 minutes here, so I'm going to just wrap up about what the future directions are and what's kind of the spin out of DOREMI. So I highlighted kind of that overlapping Venn diagram between valvular heart disease and cardiogenic shock. And so again, Richard and Trevor, we were particularly interested in use of transcatheter technologies. Now, obviously, if you're in profound cardiogenic shock, you're a poor surgical candidate. But our transcatheter technologies enable us to take incredibly sick patients to the lab and get pretty good technical results in a patient population that might not be suitable for surgical intervention. And certainly in Ottawa, I had been asked several times to take these patients with severe cardiogenic shock who are non-surgical candidates to the cath lab and do a MitraClip. And so Richard and Trevor were particularly interested in this. And so we actually, and we knew this from the conferences, lots of people were starting to do this. We reached out to everyone who was kind of working in this space and publishing in this space. And this is in late 2000, so it seems small now, but we were able to get people to give us individual patient data on 141 patients who had undergone clip and shock. And I didn't put table 1 here, but again, almost an identical patient population to the DOREMI population. So the mean age was 70, 87% of the patients were SCAI C to E, predominantly male. And again, we had very detailed data on 141 patients that had undergone this. The mortality was surprisingly low. So as I told you, your mortality should be 60% higher if you have mitral regurgitation. So if we looked at the patients that underwent CLIP, they had an in-hospital mortality of 15.6% and a 90-day mortality of 30%. So still a pretty morbid population, but lower than I would have expected for this patient population. And if we look at how CLIP performed in this very, very sick population, it performs almost identical, technically, to when we do it in ambulatory heart failure patients. So we're able to fix the valve somewhere between 85 and 90% of the time. We can get that MR down to less than 2+. So you can take these patients to the lab and in a safe fashion fix their MR while they're in cardiogenic shock. So when we submitted this paper and shopped it around, a lot of people said, well, give us the outcomes of patients who had MR who didn't get clipped. And we actually had that data and didn't feel that that was a fair comparison. One, I knew it wasn't right. So almost all the patients that had MR that didn't get clipped died. The mortality was like 80 or 90%. They're clearly a different patient population. I don't think that clip reduces mortality that much. And so we actually argued and argued and argued, but people still wanted to see that comparison. This is, I'm happy with how we did this. I didn't think that was a fair comparison, so we just refused to put that in the paper. But you do have the patients that were selected to go for CLIP who didn't get a good technical result. And so, at least people felt that they were the same population when they selected them to go to the cath lab. And when we look at that, MR reduction is strongly associated with improved outcomes. So less 90-day mortality, less rehospitalization, less incidence of a composite. Now, differences might exist. This might still be artifact. We might be able to get a better technical result because you're less sick, your ventricle's less dilated, you're not bleeding color commissure to commissure. So they might be different patient populations. But again, at least people believed that you would benefit from a mitral intervention. And so device success, which occurred in almost 90% of patients, was strongly associated with success. And actually, the TVT registry, this is, while we were doing that paper, we were simultaneously working on getting the TVT registry to look at this. So the TVT registry, as you guys know, tracks MitraClip cases in the United States. It has the baseline characteristics and procedural outcomes. And we actually, I don't see Paul here today, but we actually came up and did this paper. Trevor and I were in Texas at the Triluminate meeting that Paul was running when we came up with this idea and got this idea up and going. And Trevor published this in JACC in 2022. And it shows almost the same thing. So much larger sample size. So there's almost 3,800 patients who were in cardiogenic shock. They were on inotropes, had MCS. They underwent MitraClip. And again, 86% of patients were able to achieve technical success in the TVT registry. So people are doing these cases around the world. People are taking them and trying to clip them to improve their hemodynamic status. and it seems that technical success is achievable. And again, even lower mortality, a little bit surprisingly low mortality in this cohort, 9.1% in-hospital mortality, and 16.4% mortality if you weren't able to achieve less than 2+ MR. And by 1 year, there was a 20% absolute reduction in mortality with procedural success. So I think we can say we can clip them. We can probably get reasonable technical success at doing it. And if you get technical success, that's associated with a better outcome. Doesn't mean it's causal, but it does mean that it's associated. And so I think that a randomized clinical trial is what's needed to confirm this. I believe it, but I by no means think that we can say if you don't clip your patient, you're a bad doctor. I can't say that, I actually don't think this should be a guideline recommendation. But ironically, this is better data than we have for a lot of the interventions that we do in the cardiac intensive care unit. So what are we doing after this? So there's 2 trials that we're doing to follow up on this. The first is DOREMI 2. So Rebecca and I are running this trial together, and so we just got Canadian national funding for this trial, so this one's going to be multi-center. We'll probably have 4 or 5 centers in Canada. We're hoping to get 4 or 5 centers in the United States. And this is going to be a trial of inotrope versus placebo. So the people that thought milrinone versus dobutamine was unethical are probably going to have a harder time with this one. But probably the best comment we got in reviews at the New England was one of the reviewers said, you could just be killing both groups of patients and you don't even know it. And they're right. They're 100% right. We might just be causing harm in both arms, but that is what we do clinically. But I completely agree. Every trial that has looked at use of inotropes has shown harm. None of them have shown benefit. And so I think it's really important to know if we're harming our patients by initiating inotropes when they're hypoperfused, that's incredibly important to know. Maybe the mortality is 30% and we're tagging on 5% because of the things that we're doing trying to help. That being said, our hypothesis that inotropes are beneficial, that's what we think occurs. And so we're hoping to establish the safety and necessity of inotropes in CS. And secondarily, we've started the MINOS trial in a vanguard phase. So we're looking at use of MitraClip in patients with cardiogenic shock who are hypoperfused that have 3+ or greater MR. So DOREMI 2 is going to be 346 patients. We've actually, just to speak about the cultures you can create, so there's 2 sites, Ottawa and Hamilton, that we've got up and running in the last 12 months. Ottawa's recruited, I think Hamilton's recruited like 10 or 12. Ottawa's recruited 160 patients. So we're going to finish this trial in the next 12 to 18 months. We haven't even got the national funding yet. So we've done this with another $50,000 grant and the residents kind of leading the charge. The inotrope can be mil or dobutamine. We feel pretty comfortable that we showed in DOREMI 1 that milrinone or dobutamine can be used to encourage people to enroll, because again, we had that chunk of patients that attendings felt strongly about. We've made it so you can use milrinone or dobutamine, whatever you want, in your inotrope arm versus placebo. We did it in the initial resuscitation. We did it for 12 hours. And the reason we did the intervention arm only for 12 hours was to make people feel comfortable with randomizing their patients to inotrope. I think we went back to ethics 3 times with this one before they let us go ahead. Most patients are resuscitated by 12 hours. So the vast majority of patients are resuscitated by 12 hours with cardiogenic shock. Patients, again, most patients don't die in the initial phase of shock. So you can get most patients better from a perfusion standpoint. They still die of multi-organ failure in hospital, but you can resuscitate them. And this way, people can feel comfortable after 12 hours. They can go to open label inotropes if they aren't resuscitated. And it's very pragmatic. So it's SCAI C or D shock over 18 years of age. As long as you haven't had an out-of-hospital cardiac arrest, most of those patients die of neurologic injury, so we didn't want to confound the outcome. You couldn't have been on an inotrope for the preceding 24 hours. We only have a 12-hour intervention period, so we didn't want to contaminate it. And you can't have a severe obstructive valve lesion or dynamic outflow obstruction just because inotropes can make that worse. So again, it's very inclusive enrollment criteria. And the primary outcome is all-cause in-hospital mortality, or in those first 12 hours, if you go on more than 2 vasopressors, that's an endpoint. If your lactate is greater than 3.5 at 6 hours, we showed that lactate clearance is very predictive of mortality, a need for MCS, arrhythmia leading to emergent cardioversion or cardiac arrest. So those are all kind of our safety bailouts. If any of those bad things happen to your patient while they're either on placebo or inotrope, you bail out. What's interesting, I've looked after about 30 of these patients. I thought it was going to be, we were actually really concerned it was going to be difficult to blind because people will know what they're on. I can tell you I've looked after 30 of the patients, so presumptively half of those were placebo. I couldn't tell, which I find fascinating because I thought it was going to be pretty easy to tell. You know, my bias, and this just shows you bias, my bias is that lactate clearance would be much higher in the inotrope group, and I'm not so certain having looked after some of those patients. We've had 3 DSMBs now. Every time they're like 10-minute meetings and they tell us to keep going. So I'm guessing there's not a big signal either way. It'll be interesting to see what the outcomes of that study is. The MINOS trial, this trial is going to be much more technically difficult. We decided to do a Vanguard, so we're doing 10 patients at 4 centers. We've enrolled 7 of them in 12 months at 2 centers that we've got up and running. And again, it's funny. Centers are either like all in on MitraClip and shock or not. And so it's a bit of, again, I think of teaching the centers and getting that culture of assessing these patients. So it's going to be MitraClip versus standard of care. So you have to be comfortable. So I was in Ottawa when we rolled this out, and the very first patient we had was it's open label because it's hard to blind a clip, was a 38-year-old with severe MR, functional MR, and an EF of 15%, who had failed like 5 inotrope weans. And so then we presented him at clip rounds, and everyone was like, yeah, it's unethical to not clip them. And I was like, guys, we just went through this. You know, this is what we have to test. And so we ended up randomizing that patient. Exclusion criteria, if you've been revascularized in the preceding 48 hours, some of this MR is ischemic, so if they've been revascularized, give them a chance to get better and benefit from it. If they have degenerative MR, and they're a surgical candidate, you know, we still think that surgery would be a reasonable intervention for them, although there's not a ton of cardiac surgeons that are super enthused about taking degenerative MR to the OR in a truly shocked patient. And if they've had prior intervention, the mitral valve, endocarditis, or left-sided master thrombus. And the primary outcome, it's a hard outcome in hospital, all-cause mortality, or cardiac death. So transplant, you got a VAD, or you got discharged on palliative inotropes. And we're going to do 144 patients. So at this point, I'm going to stop, and I'd be happy to take your questions about DOREMI, MINOS, or DOREMI 2.
Man, that was just phenomenal, very inspiring. Any questions?
That was a fantastic talk, Steve Bradley. The wonderful thing is it raises as many questions as anything, right? So the first question I have for you is related to risk of type 1 error. Or I guess you gave a lot of examples of type 2 where things we thought were true and then we do more studies and it turns out, but your sample sizes are relatively small. So I was curious about your power, both in your prior study and your upcoming study. And then the other part is, you know, we get very reductive in terms of testing one component, and cardiogenic shock is very complex in terms of the pathophysiology. And I worry a little bit about the reductive nature and the potential for effect modification. And maybe it's a combination of things in the right setting, and the setting matters in terms of whether or not we see effects. So I'm curious about your thoughts about both power and how do we address complexity, but at the same time be reductive so we understand the potential impact.
Yeah, absolutely. So the sample size for DOREMI is actually the exact same. So it's a 20% reduction in primary composite outcome, which is the same, it's actually the same power size as the original shock trial. So the reality is the power calculations in shock trials tend to look for really big benefits. That's just the reality of it. And that's across the field. I think as more and more centers are getting together, we're getting to more and more individual hard clinical outcomes and probably smaller, minimally clinically important differences. So you're right, it is possible that there are some interventions that we're not adequately powered to detect smaller differences. I think for the bigger interventions, that's probably reasonable. You know, a MitraClip, the resources required to mobilize a MitraClip at 6 p.m. on a Saturday for a shocked patient, you know, you really want to make sure that you're having a big benefit. I think as we get into smaller interventions, presence or absence of a Swan-Ganz catheter, the minimal clinically important difference gets smaller. And I think we're getting to a point where we because we're able to go multi-center now and we're able to involve all these different groups, we're able to decrease that minimally clinically important difference and make the risk of type 1 error less. But I agree with you. We went from no data to okay data with some smaller RCTs that are single center, and we're starting to move towards multi-center international RCTs with larger sample sizes. So I completely agree with you. It is plausible. To answer the question about, and I agree with you, cardiogenic shock is a heterogeneous population. AMI shock is probably different than heart failure related cardiogenic shock. My only argument against all of these small things contributing, because people make that argument all the time, is twofold. We don't really know what those small things should be. So if we had good data that these small things made small differences, and if we combine them all, we might get a big difference, okay. The second thing is we haven't moved the mortality. So I showed earlier in the talk, from 2000 to 2020, mortality is bang on the same. We do a lot more things to these patients now. I think we keep them alive. I actually think, again, the way I feel about some of these interventions, I think we keep them alive for shorter periods, or for days. But in terms of bending the curve of long-term mortality, I don't think we're doing that. And I think unless we do randomized clinical trials to kind of support that, it's kind of hard to argue that our little things are doing it when we don't even know what those little things are. But I agree with you. It is a heterogeneous population. I kind of like doing the trials. So for DOREMI 2, we're actually sub-randomizing into AMI and heart failure-related cardiogenic shock, as opposed to LV-RV, because one, there's not a ton of RV, as we learned, and that's probably a better patient population to subdivide on. But I haven't seen a signal in any data set that I've played with that we're appreciably moving the needle in terms of mortality. The only one that I pay attention to, and I think it's good data, and I think it's being tested in an RCT, so I think it's a great idea, is kind of the Detroit Shock Initiative, right? So they keep showing that their mortality is lower, although the patients look less sick. And we've had fellows train at those centers, and they're very aggressive with MCS. So I think they're probably, certainly Ottawa was not a big MCS center, so I think they're probably better than we were with MCS. I don't doubt that. They do more of it, they'll get less complications, they know how to manage it better. But they also tend to put it in people that otherwise get better. Since I came to Mayo, they're much more aggressive with cardiogenic shock, and I spend most of my time talking people down, where I'm like, can we just give the meds 2 hours? If they're not better in 2 hours, I'm in. And so I always worry when you see that, that is just, you're broadening the base of your pyramid, so your mortality is going down because you're now putting it in kind of high B, soft Cs, and that is one way to make it look better in observational data. Now, they're doing the right thing. It's going to be tested in a randomized trial. If it works in a randomized trial, I'm all in. But right now, like I said, it hasn't changed in forever, so I'm uncertain that we're whittling away at it as you suggested we might be. Yeah.
Fantastic talk, David Miranda. So my question is regarding the clinical difference between right-sided cardiogenic shock or left-sided cardiogenic shock. So in the trial, just curious how you guys are differentiating that. Is it clinically or
so
with
it was
pulmonary catheter or echo?
It was clinical. So it was a clinical diagnosis. If you came in with left-sided or biventricular shock, you got counted as left and you got sub-randomized in that group. If you came in with what was felt to be isolated right-sided shock, then you got randomized to that arm. So LV is technically LV or BIV, is how, and it was a clinical diagnosis. So you could use echo, PAC, the patient's history or physical exam, whatever you wanted to classify them. You just had to pick one of the groups to put them in when you randomized them.
Thanks for your comments about the temporary mechanical support. That's obviously a big area of interest and question. Same for ECLS. So I'm glad you commented on that, which was one of the questions I was going to ask. The second one was, most of these trials and the trials that you've presented on have been 75 to 80% men. I think it's hard to imagine that there's such a sex disparity in terms of who gets cardiogenic shock. Where do you think the disconnect is? Are the women not making it to the ICU? Are they not being recognized as having shock? Why do you think there's such a discrepancy?
Yeah, so I mean, two great questions. Just to readdress the MCLS question, ACC. I think that's going to be great to see Impella. That's going to be a landmark trial. I find it interesting. It'll be interesting, I think, to see what happens to MCS curves as more and more data comes out. Because again, I can tell you, even at Mayo, like 2 weeks after ECLS shock came out, we had an AMI shock in the cath lab, and we had to intubate her, 2 or 3 pressors, lactate was 15, successfully revascularized her, and people still wanted to put her on ECMO, like as a first-line therapy. And so it'll be, I think we'll get the data. I wonder if people will be willing to let go of the practice.
Well, and of course, there's always arguments, that ECLS trial that was published. One of the criticisms of it was the mean length of stay was like 1 day. And so they were clearly withdrawing support very early in that population. So this is what makes this fun, is we have plenty to argue about.
But it is an interesting, like I said, it'll be interesting to see if people will change their practice with the evidence, even as we accrue it. Because again, it's really hard when someone's dying. So forget running the clinical trial, but then when you have the evidence in hand, are you willing to, quote unquote, bend the knee to that? With regards to the question about women, it's interesting. So we've looked at this a couple of ways. So we have a database, I'm sure you guys do, of all your shock patients. So men do present more commonly with cardiogenic shock. So you get into the database. If you get into the database, you're more likely to be male. Now, exactly like you said, that might be that nobody applies the label to you. So there could be a discrepancy in diagnosis or ascertainment bias in how you label that. That's possible. The second issue is willingness to enroll in clinical trials. So we looked at when patients, so most patients agree to go in these studies, which again, every time we present this to ethics, everyone's like, why is a patient going to go in this trial? And actually, when you explain to patients, we have this drug therapy, we routinely use it, we don't know if it works or not, we do randomized trials to learn, most patients and their families will actually agree to go in the clinical trial. So patients aren't the normal barrier. Doctors are far more likely to not allow their patient to go in than the patient is to refuse to be in the trial. But when we looked at when patients or family members don't want to go into clinical trials, women are more likely to opt out. Men tend to be more agreeable to go into the trial. And we've seen this pattern in some of our other studies. So AltFlow was one where in Canada we had substantially more men than women. And we were approaching, HFpEF is more common in women, and we were approaching more women, but women were less likely to be agreeable to go to undergo an experimental intervention. So I do think there are probably some sex differences in willingness to enroll in clinical trials. And again, that's just part of, I think, the importance of educating, the importance of, and we'll talk to patients when I'm talking to patients. I'll say, we're running this clinical trial, blah, blah, blah. Women are less likely to receive advanced therapies. They seem to present less. We're trying to learn, and having women in trials is really important. And I think when you place it in that context, sometimes it can encourage them a little bit more. But I have no doubt there's probably a diagnostic problem where we're labeling them less. So when we look at our data sets, men tend to be a little bit more prevalent. But then when we're approaching them for intervention studies, there's also less conversion to enrollment. And that might just be differences in risk tolerance.
Again, congratulations, phenomenal work, and I was very fascinated by having the resident and fellow team do all the work. So a couple of questions.
He's like, as God intended.
So a couple of questions regarding, first of all, how do you motivate them to do this? And number two, sometimes there's a concern about the regulatory, will they do the right thing, miss the forms, have all these issues. So those two key things, how do you address them?
Yeah, so, I mean, again, I was their boss. No, I didn't make anyone participate in it. So, this is basically, and actually we have the opposite problem now, because now people see the fruits of the labor. People are super keen to participate. But we just put it out there to the residents that wanted. Not every resident in the program was involved in the trial, so if people didn't want to, they didn't have to be. And the people that wanted to be were. And so, kind of the agreement, and all of the, Rebecca and Pietro are the first authors, shared first authors on that New England paper. All of the sub-papers are led by residents, and we literally look at how many patients people enroll, what roles they had in the trial, and when we sit with the data set at the end and we divvy up all the papers, the people that did the most work, get their shots at writing their papers. And so kind of the quid pro quo is they get the opportunity to present and publish, and I hope advance their careers. And that's been enough for a lot of them. There's no doubt there's some trainees who are not interested in it. They don't see academia as part of their career, and I have tremendous respect for that. We need great clinical cardiologists, but within a program of a reasonable size, if you can get a team of 4 or 5 working on a study, that's usually enough to run a study. The interesting thing, I run, I did Triluminate, I did Allflow, we had like 20 industry-sponsored clinical trials, and we had about 4 or 5 kind of resident-run clinical trials. I don't think there was any more regulatory issues with the resident-run clinical trial than there was with the industry-sponsored one. Trainees we're super fortunate, right? We get incredibly motivated, incredibly bright people. If you provide them with the support, the supervision, and are available to answer the questions. I mean, these people learn to put people on ECMO and manage them on ECMO. They can learn the process of running a DSMB, filling out case reports, doing adverse event reporting. They need a little bit of guidance to help them with that because it's not an easy thing to navigate as you're learning it. But these are incredibly bright, motivated people, and I actually don't think it was that difficult for them. And in my experience, like I said, I don't think there was any more or less issues with regulatory with the resident-run trials that I've done. And I've done 6 or 7 now. This one got in the New England, so it gets a lot of press, but we've done a lot of randomized trials that have been run by residents. The Safari trial, which was in JAMA, which was a randomized trial of femoral versus radial in STEMI patients for primary PCI, was 2,000 patients. 98% of the patients in that trial were put in by residents, and the data collected by residents. We did Capital Chill, which was also in JAMA. 100% of those were put in by residents, and the data collected by residents. And again, I don't think we had any more problems with it. So, and it's been a great model. It's not, I will admit, we've run it at a couple of other sites. It's a little bit harder to run at other sites. I'm hoping to get it up and running at Mayo, so I'm hoping to kind of start that process with Minos and DOREMI 2 at Mayo. And it's a culture thing. It takes time to build. Like I said, in Ottawa, we have the opposite problem now because everybody wants to participate, and we almost have too many trainees involved. And we're randomizing like crazy in our clinical trials because they've seen kind of the accolades and the ability to get jobs and be promoted based on their success.
Congrats, Ben. It's inspiring to see what it's possible. And yes, certainly a cultural thing. You have planted the seeds and the seeds are growing. And now, with other ones that you have left, you still continue that tradition. I was wondering about the Minos one, about actually the predictability of achieving MR reduction, right? Because that's going to be the crux. And should there be a third arm to not complicate things further, that in patients that you see anatomy does not look good for clip. Yes, you could clip, but boy, this is going to be really tough. Should there be an unload arm? What do we know about that? Because, could that be also another?
Yeah, I mean, to be completely honest, I hadn't thought of that. That's an excellent point. When we've only been running it in 2 sites for about 12 months now. The thing that seems to be the biggest barrier right now is still, again, sites are either like, it's unethical, this patient has failed 3 milrinone weans, we have to do it. So still the clinicians who, are anchored in this as a therapy, or actually the inability to mobilize a team. I don't know how facile it is here. At Mayo, it's incredibly easy. We're very blessed. You can do a clip seemingly whenever, but when I was in Ottawa, it's Fridays. It's Friday's the clip day. And so you come in Saturday night in shock, you're like hanging on by your fingernails until we can get to our regularly scheduled programs. But that's an excellent point. There's probably going to be patients in whom we're unable to achieve good MR reduction. We should probably be looking at other therapies for those patients. The thing that makes me encouraged about clip as a therapy, I've done a bunch of them in shock. It is incredible when you get rid of MR. as you do in the ambulatory output, their blood pressure comes up. Like their forward stroke volume goes up. You're modifying the natural history of their disease. As opposed to MCS. MCS, I always like, MCS is you are stabilizing people. You're trying to prevent like the inflammatory milieu and the sequelae of shock, but you're not actually changing any of their biology. And at some point, you're taking that away, hopefully. So, unless you have something more definitive to offer them, I know that the term bridge to nowhere gets used all the time, but you're not really moving their biology. I'm encouraged by CLIP as a more definitive therapy because you're hopefully modifying their stroke volume for a longer period of time. I will say, also having looked after them, they're still incredibly unwell patients. So one of the problems we've suffered with, not in the trial because we're following them closely, but I've probably clipped about 30 or 40 of these patients clinically, is whatever, we clip them, their pressors come off in 24 hours, we high five, and then they get sent to the bedside and they get sent home on like one, GDMT drug, and nobody sees them for like 4 months. And it's not uncommon that, again, like we'll clip them, we'll drag them through, we'll get them out, and then the next presentation is shock, sometimes months later, before they've been seen. And often what happens is they weren't feeling well, so someone stops their GDMT. So, I think that, CLIP is a little bit of a crutch to get you out of that stormy sea of cardiogenic shock, get them into a better place, and hopefully make them a candidate under more stable circumstances for something definitive. I think, ultimately, if this does work, that's how it's going to have to work. I don't think it's a fire, forget, and the patient's cured. These are patients that are hanging on by a thread. The MR gives them another thread to get, back to a better place for more definitive therapies. And if you're not going to do the latter part, don't spend the resources and the time doing the former part, even if you get them out of hospital, because you're just so. What I did in Ottawa is they just became my patients. Like they got a clip and they, were followed by an interventional cardiologist, which probably isn't the best thing for them, but was better than nobody seeing them, because I do think it's a temporizing measure.
I'll squeeze in one last question, and I know we're past 8, but this has just been wonderful. But as you know, I've been very interested in clinical trial design, and you've alluded to this several times. Maybe you want to speak briefly on what a pragmatic trial is. But you've been, 6 months now in the U.S., and I'm very interested in your thoughts of the future direction of clinical trials, particularly in the U.S., where we're still, I feel, for the most part, still in traditional setup. Coordinators, 8 to 4 to 5, large budget. Even if you want to do an observational study, they're going to tell you, $200, $500, $1 million for. You're doing clinical trials outside the U.S. You said what, $30K for a trial? So I'm just interested in, is that the future? How do you tackle that? How do you jump into that?
Yeah. So again, I'm going to speak from a place of being a little bit naive because I'm still learning, but I can tell you that the expectation of what a clinical trial is and how it's run, at least at Mayo, because that's my experience, is completely different than what it is in even industry-sponsored trials. So a pragmatic trial is when we design these studies, we're testing, first of all, usually interventions that are accepted standards of care or being utilized as standards of care. So the intervention is part of what we're doing anyways. The follow-up and the endpoints might not be all the follow-up and the endpoints that you would want to answer your scientific question, but they're integrated in the patient journey so that you're not generating more visits, you're not generating more endpoint assessment, you're not generating more cost to the study, so that the follow-up is all integrated in their clinical care. And again, we try to make the endpoints pragmatic, clinically relevant, things that are easy to adjudicate that we're not going to have to do more testing for, because all of that drives up cost. This concept, it's funny, this concept of having trainees do it as part of their learning gets a lot of pushback at Mayo. And again, I think that's in part because Mayo's a big ship, it's difficult to turn, and people just aren't used to the concept. But like I said, you have incredibly bright, motivated people who are often there for 5 to 8 years. So when I meet with trainees and I tell them, and they come and they sit in my office and they're internal medicine, they're like, I want to be a critical care cardiologist. I'm like, that is phenomenal. And they're like, I want to be an academic critical care cardiologist. I'm like, even better. And I was like, you're going to be here for 5 to 8 years, so let's get you 3 or 4 observational data sets to play with, and let's pick one big project that we're going to do longitudinally. These people are going to be here for a period of time. They can conduct a clinical trial. And again, we've done several of them during people's training period. So Rebecca, started this when she was a C1, and her first year of staff, that was published. And I think that's a great kind of arc of starting a project, running it through, analyzing the data, publishing it, and kind of getting the fruits of your labor. It's funny, so we got national funding. The costs of running clinical trials, I think because of the way they're done from a regulatory standpoint here, is more expensive. So Mayo is about 8 times more expensive to run everything than Ottawa was. When I submitted the budget for DOREMI 2 to Mayo, the research manager actually laughed, and she's like, "What is this?" And I'm like, "This is the budget that everyone else in the world is running this trial on. Why can't we do it?" And I think part of that is also culture of the institutions, right? So some institutions view research as a way to make money. So it's a revenue generating activity rather than an academic activity. And don't get me wrong, you have to pay the bills, you have to keep the lights on. But especially for pragmatic trials that are trying to answer this isn't a new device that we're trying to get approval for that's going to turn around and be sold for millions of dollars. You're trying to answer fundamental questions in cardiology, questions that we have at the bedside about how to treat our patients. I think accepting that you can use your residents as part of their training to learn how to run clinical trials. They get the academic benefit, and doing that at lower cost. I think that's just a culture change, and I think I'm hoping I can do it, but we'll see. And I think kind of dividing those pragmatic trials from those like industry-sponsored new indication, almost business of research trials. I think they're different animals, and I think the regulatory requirements for those might need to change a little bit to facilitate generating more data.